I welcome you all on today's session of colorectal malignancy. Colorectal malignancy is the most common malignancy of gastrointestinal tract, major cause of morbidity and mortality worldwide. Colon, including rectum, hosts to more primary neoplasm than any other organ in the body. Epidemiology. It is most common cancer in Western societies. Second most common cancer death after lung cancer is seen. In lifetime risk, 1 in 10 for men and 1 in 14 for women. It generally affects patients above 50 years. More than 90% patients are seen above 50 years. Histopathologically, it is mainly adenocarcinoma. The forms are hereditary or sporadic. Hereditary is seen in 20% of cases where family history is positive. It is younger age, that is onset will be less than 50 years, and specific gene defects will be present. Example in familiar adenosis polyposis, that is FAP, hereditary monopolyposis colorectal cancer, that is HNPCC, or called as Lynch syndrome. In sporadic, 80% patients are seen. That is absence of family history in older population, and then it will be isolated lesion. Now we'll come to etiology. We'll see the risk factors first. The first risk factor is past history of colorectal cancer or pre-existing adenoma, patient with ulcerative colitis, and patient receiving pelvic irradiation. Family history, first degree relatives in less than 50 years of age, and relatives with identified genetic predisposition like we have already seen, like in FAP, HNPCC or Peutz-Jeghers syndrome. They are having more risk of developing malignancy. Diet carcinogenic foods can produce malignancy. Now we'll come to environmental influences. First is dietary practices. Low content of unabsorbable vegetable fiber is supposed to be very important factor in causing malignancy. More intake of animal fat. Third is corresponding high content of refined carbohydrates. Decreased intake of protective micronutrients like vitamins A, C and E, calcium, selenium, carotenoids and plant phenols will cause malignancy. Increased roughage is associated with reduced transit time, and this in turn reduces the exposure of mucosa to carcinogen. Pelvic irradiation remains very important causative factor. Patients with long-standing colitis from inflammatory bowel disease are at higher risk. Now the questions which are usually asked are: diet containing less or more animal fat will cause CA colon. Second is whether patient of ulcerative colitis, Crohn's disease, polyps or any fourth option will be given, who is at more risk of having malignancy. Third question will be asked as carbohydrates increase intake with fat, will it cause? And fourth question, which is very important, is high fiber diet. If it is high fiber diet, then malignance chances are less. Risk category for asymptomatic patient will be 1, 2 and 3. In category 1, there will be twofold risk. First degree and second degree relatives with colorectal cancers and patient more than age of 55 years. Category 2, that is 3 to 6 fold of risk, that is first degree relative more than 55 years of age, or say first to second degree relative at any age. And category 3, that is 1 and 2, having HNPCC, FAP or other mutations which are genetic mutations which are identified. Now we'll come to microscopic how it will look. There are 4 common varieties of carcinoma of colon, and as I have drawn, these are annular, tubular, this is ulcerative and this is cauliflower. These are the 4 varieties which are seen microscopically in CA colon. Now morphologically, all colorectal carcinogens begin as in situ lesions. Tumors in the proximal colon will have polypoid, exophytic masses that extend along one wall of the cecum and in ascending colon. In the distal colon, annular encircling lesions that produce napkin ring constrictions of the colon and narrowing of the lumen is seen. Both forms of neoplasm eventually penetrate the bowel wall and may appear as firm masses on serosal surface. Site of carcinoma colon. Now this is a very important slide, as you will see percentage of carcinoma occurring in different parts of the colon. The question which is very commonly asked is which part of the colon will have higher percentage, that is rectosigmoid. I will just tell you the percentage. Cecum is 12%, ascending colon will be 5%, transverse colon 5.5%, splenic flexure 3%, descending colon 4%. Now note, sigmoid colon is 21% and rectum is 38%. So mainly seen in rectum and sigmoid. But after that it is cecum. Routes of spread, there will be 3 routes of spread: local, blood and lymphatic. We'll see all in details. Now we'll come to local spread. The tumor can spread in longitudinal, transverse or radial direction. It spreads around the intestine and cause intestinal obstruction before it invades the adjacent structures. Ulcerative type can invade locally, forming fistula like we can see it in bladder. There may be perforation with an abscess or even formation of fecal fistula. The progression of invasion occurs from mucosa, then to submucosa, then to muscularis propria, serosa, then fat, lymphatic and veins in the mesentery alongside the bowel wall. Now we'll come to lymphatic spreads. Lymph nodes are grouped as follows: N1, N2 and N3. N1 are the nodes in the immediate vicinity of the bowel wall. N2 are the nodes along the ileocolic, right colic, mid colic, left colic and sigmoid arteries. And N3 are the apical nodes around the superior and inferior mesenteric vessels where they arise from the abdominal aorta. We'll come to blood spread, and it is mainly seen in the liver. 1/3 of cases of colorectal cancer will have metastases in the liver. They will present with hepatic pain and jaundice. If they spread to lung, there will be cough. If bones are involved, then leukoerythroblastic anemia is seen. Other organs which are involved are brain or peritoneum. In peritoneum, if it is involved, then there will be ascites or systematic Joseph's nodule also can be seen. Now we'll come to clinical features. Now you should always pay more attention to clinical features, because clinical features of right-sided colonic carcinoma and left-sided colonic carcinoma are slightly different. The question can be confusing because on left side the symptoms will be different and on the right side the symptoms are different. So I will just tell you in detail. In cecal and right-sided cancer, it is mainly fungating and cauliflower growth. The patient will have symptoms like iron deficiency anemia, palpable mass, and late it will be distal ileum obstruction. On left side and sigmoid carcinoma, most common lesion will be stenosing. So as the name suggests, patient might present first with obstruction, or he might present with change of bowel habits like alternating constipation and diarrhea, and tenesmus. Colicky pain and distension is also seen. So on the right side, you will find that patient will have first the iron deficiency anemia because of losing blood, and second will be palpable mass, whereas on left side the first sign or symptom of patient will be obstruction. The second will be alternating diarrhea and constipation, and then comes the other symptoms. So that is basically symptoms differ on the right side and on the left side. Third will come to sigmoid carcinoma. Patient will have PR bleeding, mucus and stool, tenesmus, change of bowel habits, and bladder symptoms may be due to colovasacal fistula. Constitutional symptoms are seen like loss of appetite, loss of weight, and malaise. If there is bowel obstruction, we'll see features of bowel obstruction. If there is local invasion, patient might present with bladder symptoms, or if it is a female, then female genital tract symptoms might be present. And if there is Metastasis like liver metastasis or lung metastasis or bone, like I have already told you, patient might directly present as having jaundice or ascites or for cough, and then you have to find out what is a primary site. Signs of primary cancer. There will be abdominal tenderness and distension causing large bowel obstruction. Second will be intra-abdominal mass. On digital rectal examination, in the lowest 12 centimeter, if the mass is present, then you can feel it on the examiner finger. On rigid sigmoidoscopy, you can see that. Signs of metastasis and complications. The signs of anemia will be seen. Hepatomegaly due to metastasis. Monophonic wheeze or bone pain will be seen. Now we'll come to investigation. First is the fecal occult blood. The test is done as Guillain test based on the pseudoperoxidase activity of the hematine. The sensitivity is 40 to 80% and specificity is 98%. But before doing this test, you have to have dietary restriction. That is, avoid red meat, melons, horseradish, vitamin C and NSAIDs for 3 days. Immunochemical test based on antibodies to human hemoglobins is done. It is used for screening and not for diagnosis. Now we'll come to a very important investigating finding, and that is on colonoscopy. Investigation of choice of colorectal cancer is colonoscopy. It has advantage of picking up primary cancer and can also detect synchronous polyps or even multiple carcinomas, which occur in around 5% of cases. Full bowel preparation and sedation are necessary. Small risk of perforation and failure to get to the cecum is 10% of cases, and it can visualize lesion less than 5 mm. Now the question which is asked is, which is an investigation of choice in CA colon? And it is colonoscopy, because it will tell you where is the lesion, you can take the biopsy, you can send it for HPR, and you can confirm your diagnosis, and only then you can plan your surgical treatment. Double contrast barium enema is useful when colonoscopy is contraindicated. It shows a cancer of the colon as a constant irregular filling defect. It does not require sedation and also avoids risk of perforation. Endorectal ultrasound will determine the depth of the lesion. Mesorectal lymph nodes involvement will be shown. It does not require any bowel preparation, or sedation also is not required. It helps to choose between abdominoperineal resection or ultra-row anterior resection, because you'll know which lymph nodes are involved, so you can decide between these two operations. The other investigations can be CT and MRI that will involve and give us exact stage prior to the treatment. Blood test will be done. Tumor marker CEA, useful for monitoring the progress, that is, it is of prognostic importance and not used for diagnosis. This is a very important point. CEA is used for prognostic importance, not diagnosis, and also it is a very important question that CEA will be prognostic or diagnostic in which disease. Now we'll come to TNM classification. T suggests tumor stage, N suggests nodal stage, and M for metastasis. So T1 is submucosa, T2 muscularis propria, T3 pericolic fat but not breaching the serosa, and T4 it breaches serosa or directly involving other organ. In N0 is no nodes are involved. N1, 1 to 2 nodes which are involved. N2 will be 3 or more nodes if it are involved. In metastasis, M0 is no metastasis, M1 is there is metastasis. We also can find out whether there is lymphatic invasion and if venous invasion is there or not. Now we'll come to TNM staging. There is difference between TNM staging and Dukes. So I'll first go to TNM. TNM stage 0 is TIS N0 M0. That is small tumor within the lining of the colon or rectum. Stage 1 is T1 N0 M0 or T2 N0 M0. The tumor has invaded layers of colon without spread beyond the wall. Stage 2 will be T3 N0 M0 or T4 N0 M0. That tumor has spread beyond the wall into the nearby tissue but no lymph nodes. In stage 3, any T, any N but no M0, that means spread is to nearby lymph nodes but not to other organs. Stage 4 will be any T, any N and M1, that is spread to other organs. Now we'll come to Duke staging. Duke staging, the question asked is, Duke staging is done in which diseases? So it is colorectal carcinoma which Duke staging is usually done. And it is Duke A, tumor confined to bowel wall. Duke B is tumor invading the serosa. And Duke C is lymph node involvement. And 4 of course remains distance metastasis. Preoperative preparation for this surgery. Special diet is given 2 days prior. The patient is kept on liquid diet. Mechanical bowel lavage should be given, so patient will not have any feces when operating on the colon. And third, antibiotics are given orally a day before operation, and parenteral broad spectrum are given prior to skin incision. Again, a favorite question asked is, what are the prerequisites or what are the preoperative preparation done in patients with colorectal carcinoma? Or the second question, which is confusing, is asked, when the antibiotic, parenteral antibiotic, when is it given? And you don't start it 48 hours prior to the surgery. You start it just before the incision is taken. Now we'll come to the treatment. If the lesion is involving cecum or ascending colon, right hemicolectomy is done and anastomosis done between the terminal ileum and transverse colon. If the lesion is close to the hepatic flexure, right hemicolectomy is done. If mid-transverse colon is involved, extended right hemicolectomy up to the descending colon is done with omentum, which is removed en bloc with the tumor. If splenic flexure is involved, then we do subtotal colectomy, that is up to sigmoid we remove the colon. Descending colon Hartmann's procedure is preferred, but if it is not possible, then left hemicolectomy is done. In sigmoid colon, high anterior resection and anastomosis of mid-dissecting colon to upper rectum is done. Now if there is obstructing colonic carcinoma, if it is right and transverse colon, then resection and primary anastomosis is done. If there is left-sided obstruction, Hartmann's procedure is done, where proximal end colostomy is done, oversewing the distal bowel, and it can be reversed in 4 to 6 months depending on how is the lesion and depending on how is the response. Then primary anastomosis can be done and subtotal colectomy, that is iliosigmoid or iliolectal anastomosis can be done. Intraoperative bowel preparation with minimal, that is 5% anastomosis leak is seen. As you can see, in obstructive bowel carcinoma or colonic carcinoma, the feces will be there. So intraoperative, you can give bowel irrigation, but then there will be chances of bowel leak. So again, this is one of the questions which is asked, that when will you give intra-op bowel irrigation? And it is in obstructive colonic carcinoma that you can give intra-op bowel irrigation. Proximal diverting stoma is done and then resection is done 2 weeks later. Sometimes palliative stents also can be tried. When the growth is found to be inoperable, in the upper part of the left colon, ileostomy is preferred. If it is in the pelvic colon, left iliac fossa colostomy is done. In the ascending colon, a bypass using ileocolic anastomosis is the best procedure. A total colectomy needs to be considered for multiple tumors. Adjuvant therapy, that is chemoradiation, should be given. Now we'll come to rectal cancer. The options are low anterior resection, transanal local resection, abdominoperineal resection, and palliative procedures. Now the factors influencing choice, how will you decide which procedure to do? So it depends on level of lesion, distance from the dentate line. If it is less than 5 centimeters, then requires abdominoperineal resection to obtain adequate margin. We'll see the grade. Poorly differentiated, then larger margin is required. Patient factors, and then incontinence is very important. Mesorectal nodal status. We have to resect lymph nodes if there are metastatized. Abdominoperineal resection. If there is larger T2 and T3 or poorly differentiated tumor, then you should go for it. Rectum is mobilized to pelvic floor through the abdominal incision. Sigmoid and colostomy is done. Separate perianal elliptical incision is done to mobilize and deliver anus, and the distal rectum, that is a Hartmann's procedure, will be done. Transanal local excision is done only in early stage, but it is too low to allow restorative surgery. En bloc resection for locally advanced colorectal carcinoma is done to remove adherent viscera and abdominal wall. Other palliative procedures can be diverting stoma, radiotherapy, chemotherapy, some local therapies like laser beam, electrocoagulation and cryosurgeries can be tried, and nerve block can be given. Now we'll come to treatment of recurrent colorectal carcinoma. In 20 to 40% of patients can develop recurrent disease. Most recurrences occur within the first 2 years after the initial diagnosis. But whether you are given chemoradiation preoperatively or not, the delay can occur. Most of the patients will present with distant metastasis. Some will have isolated local recurrence and may be considered for salvage surgery. Recurrence of rectal cancer is more difficult to treat because the proximity of the other pelvic structures. If the patient has not received chemotherapy radiation, then adjuvant therapy should be administered prior to the salvage surgery. Radical resection may require extensive resection of the pelvic organs. For that, you must do pelvic MRI. It will be useful for identifying the tumor extension. Identify distant metastasis before doing it. We will do CT chest, abdomen and pelvis, and PET scan before undergoing such a radical procedure. Radical salvage surgery can prolong survival only in selected patients. If there is single liver metastasis, then resection should be done. Now we have come to end of colorectal malignancy. It was a very important topic because colorectal malignancy is a major malignancy which is seen worldwide, and I hope you have understood it. Thank you.